A 32-year-old woman with type 1 diabetes mellitus has had progressive renal failure during the past 2 years. She has not yet started dialysis. Examination shows no abnormalities. Her hemoglobin concentration is 9 grams per deciliter, hematocrit is 28%, and mean corpuscular volume is 94 cubic micrometers. A blood smear shows normochromic, normocytic cells. Which of the following is the most likely cause? A. Acute blood loss, F. Microangiopathic hemolysis, B. Chronic lymphocytic leukemia, G. Polycythemia vera, C. Erythrocyte enzyme deficiency, H. Sickle cell disease, D. Erythropoietin deficiency. I. Sideroblastic anemia, E. Immunohemolysis, J. Beta thalassemia trait. The correct answer is D. Erythropoietin deficiency. This patient has chronic kidney disease due to long-standing type 1 diabetes mellitus. Her anemia is normocytic and normochromic, which is classic for anemia caused by chronic kidney disease. Normally, the kidneys produce erythropoietin, a hormone that stimulates the bone marrow to produce red blood cells. In renal failure, erythropoietin production decreases, leading to reduced red blood cell production and anemia. This patient has chronic kidney disease, CKD, from long-standing type 1 diabetes, normocytic, normochromic anemia, low hemoglobin hematocrit, no evidence of bleeding or hemolysis. In CKD, the diseased kidneys cannot produce enough erythropoietin, EPO, the hormone that stimulates red blood cell production in bone marrow. This causes a classic normocytic, normochromic, hypoproliferative anemia. Key concept: the kidney normally produces erythropoietin in response to hypoxia. Now let's discuss each option. Option A, acute blood loss. Acute bleeding can initially produce a normocytic anemia, but there is no evidence of hemorrhage, trauma, or gastrointestinal bleeding in this patient. Acute blood loss usually causes initially normocytic anemia, history of trauma, surgery, GI bleeding, etc. Reticulocytosis develops after several days. Why incorrect? No bleeding history. Chronic progressive renal failure strongly points elsewhere. Option B, chronic lymphocytic leukemia. This condition is usually seen in older adults and is associated with lymphocytosis and abnormal lymphocytes on blood smear, which are not present here. Chronic lymphocytic leukemia, CLL. CLL causes bone marrow infiltration, lymphocytosis, often older adults 60 years. Peripheral smear would show mature lymphocytes, smudge cells. Why incorrect? Young woman, no abnormal WBC findings. Smear only shows normal appearing RBCs. Option C, erythrocyte enzyme deficiency, such as G6PD deficiency, causes hemolytic anemia with jaundice and evidence of red blood cell destruction. This patient does not show signs of hemolysis. Erythrocyte enzyme deficiency examples: G6PD deficiency, pyruvate kinase deficiency. These cause hemolytic anemia with reticulocytosis, jaundice, elevated LDH, Bite cells or Heinz bodies. Why incorrect? No hemolysis signs. Normocytic anemia due to CKD fits better. Option D, erythropoietin deficiency, is the correct answer. Chronic kidney disease reduces erythropoietin production, causing a normocytic normochromic anemia, classic in chronic kidney disease. Features: normocytic normochromic anemia, low reticulocyte count, due to decreased renal EPO production. Very common in diabetic nephropathy, chronic renal failure. Option E, immunohemolysis, also known as autoimmune hemolytic anemia, would present with hemolysis, spherocytes, elevated bilirubin, and a positive Coombs test. E, immunohemolysis. Autoimmune hemolytic anemia causes hemolysis, spherocytes, elevated bilirubin, positive Coombs test. Why incorrect? No evidence of hemolysis, smear is normal. Option F, microangiopathic hemolysis, occurs in disorders like TTP, HUS, and DIC. Blood smear would show schistocytes or fragmented red blood cells. Microangiopathic hemolysis. Examples: TTP, HUS, DIC. Smear shows schistocytes, helmet cells. Why incorrect? No fragmented RBCs. Clinical picture is chronic CKD anemia. Option G, polycythemia vera, causes excessive red blood cell production with elevated hemoglobin and hematocrit, not anemia. G, polycythemia vera. This is increased RBC production. Features: elevated hemoglobin, hematocrit, hyperviscosity, JAK2 mutation. Why incorrect? Patient is anemic, not polycythemic. Option H, sickle cell disease, causes chronic hemolytic anemia with sickled red blood cells and painful vaso-occlusive crises. H, sickle cell disease, would show hemolytic anemia, sickled cells, pain crises. Why incorrect? Smear would not be normal, usually diagnosed earlier in life. I, sideroblastic anemia, is usually a microcytic anemia associated with ring sideroblasts in the bone marrow and abnormal iron metabolism. Usually, Microcytic anemia, ring sideroblasts in marrow, increased iron ferritin, causes alcohol, lead poisoning, vitamin B6 deficiency. Why incorrect? MCV is normal, 94. CKD explains findings better. Option J, beta thalassemia trait also produces a microcytic anemia with target cells on blood smear. The key teaching point is that chronic kidney disease commonly causes a normocytic normochromic anemia due to decreased erythropoietin production by the kidneys. Beta thalassemia trait, typically mild microcytic anemia, low MCV target cells. Why incorrect? This patient has normocytic anemia, no thalassemia smear findings. High-yield exam point. Chronic kidney disease anemia, EPO production, normocytic normochromic anemia, low reticulocyte count, treated with erythropoietin analogs, iron supplementation if needed. Common USMLE NBME association. Open quote, diabetes, CKD, EPO deficiency anemia.